Hi, welcome everyone to the second session of STEP. STEP stands for Simplifying Training and Education in Pain Medicine. The session today is on contrast agents, and I think this is very important because selecting the right contrast not only helps you to avoid complication but also simplifies your procedure. And if you haven't got the right contrast, you're more prone to have complications. So, as we all know the reasons why we use contrast. Common ones being like we want to make sure where the needle tip is, we want to make sure that the medications we're giving are delivered in the right area, we want to make sure there's no intravascular uptake, especially if you're doing things like medial branch blocks, where you're giving a very tiny amount of medication. If that's going intravascular, then you will get a false negative result, which is kind of going to have a bearing on your future procedures. Then in procedure like racks, we are kind of using it to delineate the anatomy. When we give the contrast agents, we know where the contrast is flowing and we try and open up that area if it's not flowing into a specific area, which can again then help us determine the efficacy of our treatment. So the common thing in all these contrast agents is the iodine, and iodine specifically is chosen because it has got high contrast density, which effectively means that the X-rays are not able to penetrate, and hence we see the opaque appearance on the X-rays, which helps us to determine where the medication is going or the contrast is going. Now, it also has an advantage of low toxicity. So even if you're going intrathecal, you can use a high amount of iodine, as much as 3 grams per day, and it's recommended as being safe. Now, these contrast agents we use, we need to know about their chemical and physical properties a little bit. So if I was to show you a contrast agent, which is like Omnipec over there, the chemical formula of that, you can see there is a benzene ring in there. Then there are 3 iodine atoms at position 2, 4 and 6. And then there are side chains attached to position 3 and 5. And there is a acid group at position 1. So there's only one benzene ring in this chemical formula which I'm showing. So it's a monomer. Diamers are the ones which will have more than one benzene ring. So that is one thing which you need to know about monomers and diamers. The second thing we need to know is these contrast agents can be ionic or non-ionic. We'll talk about these in a little bit later in detail. So if they break into anions and cations, they are ionic contrast agents. And when they break into two different molecules, anions and cations, then the osmolality or the number of particles per liter per kg of solvent increase. So that's important to keep in mind. Now, osmolality, as we all know, is the number of solute particles per kg of solvent. And the contrast agents can have high osmolality, which is graded as something like 5 to 8 times that of plasma, or they can be isoosmolar, which is similar range as plasma, or they can be low osmolality, which is up to 2 to 3 times of the plasma osmolality. The higher the osmolality of the contrast agent we are using, the more the chances of pain when we are injecting that agent. So moving on from there, ionic and non-ionic contrast, the ones which we use generally are the non-ionic ones. And the reason for that being that these ones are less lipophilic and more hydrophilic. So when they're hydrophilic, they don't combine so much with the proteins and the macromolecules, and hence the toxicity is reduced. Also, their osmolality is generally on the lower side. Whether that be iso or low osmolality is a different issue. But these ones are tolerated better. They have less neurotoxicity and less allergic reactions. So the common ones which we use normally are the Omnipec, which is chemically iohexol, and the concentration of iodine is almost, depending on what strength you're using, it is variable between 200 to 300 milligrams per ml. So if you talk about Omnipec, this is a chemical structure which we've discussed a little bit before, and it comes in various strength or forms. As we discussed before, there are iodine atoms at position 2, 4 and 6. there is a acid group in position 1, which forms amides and salts and influences the water solubility. At position 3 and 5, there are basically the side chains which make it less lipid soluble and hence reduce the chances of complications. Now, as we discussed before, Omnipec comes in different forms or strengths, such as 140, 180, 240, 300, and 350. Of these, I specifically have used 240 and 300. When we talk about 240 or 300, what we mean is the strength of iodine per ml. So we're talking about milligrams of iodine per ml of the contrast agent. So 240 would have 240 milligrams of iodine per ml of contrast agent. So as the iodine concentration increases, so does the osmolality. So if you notice, the 241 over there has an osmolality of 520, which is significantly more than that of plasma. And the 301, which is more commonly available, has an osmolality of 672. The 351, which is used in for IV procedures, has got osmolality of 844. So if you compare between 240 and 350, there is a significant change in the osmolality. So what I want to highlight over here is that for spinal procedures, if there is a chance of the contrast going intrathecally, then you should not be using anything more than 300. So the commonly used ones are 240 Omnipec and 300 Omnipec. These are the ones which are most commonly used for procedures where there can be uptake intrathecally. Another point which I want to highlight over here is we don't dilute contrast agents normally, but they can be easily up to 25%. So if you're taking about 10 ml of contrast, you can dilute about 7.5 ml of contrast with another 2.5 of saline for fluoroscopy procedures. For CT guided procedures, I dilute it much more because once you've injected the contrast, otherwise everything becomes very, very bright. So I dilute it significantly using more amount of saline for CT guided procedures. So once you've injected the contrast, it goes, let's say it's gone intrathecally. From there, it will be taken up in the blood, and then majority of it is excreted renally. Once you've injected it intrathecally, like for a myelogram, which is done mainly by the radiologist, it stays there for approximately at least 30 minutes, and it can be there even up to 1 hour. Now, the important thing of this contrast Omnipec is that it's light sensitive and there are no preservatives in it. And if it does end up going intrathecally for any reason, it can lead to side effects as well. And hence it's important not to be using the 140 and the 350 strength of Omnipec where there is a chance of intrathecal uptake. So just moving on a little bit, now what is important when you're selecting your contrast is the ratio of the osmolar particles to the iodine. So this is what determines how your contrast appears and what osmolality would be there, which is indirectly related to the complications it may cause. So let's talk about ionic contrast agents. Ionic contrast agents would have two particles because they'll have cations and anions. And let's say there are monomers. Monomers means there is only one benzene ring. So an ionic monomer would have one benzene ring but two osmolar particles. So the one benzene ring would give us 3 iodine. So if you talk about the ratio of osmolar particles to iodine, what we are getting is 2 osmolar particles, which are the anions and the cations, and 3 iodine molecules, which gives us a ratio of 2 osmolar particles to 3 iodine molecules. If we talk about diamonds, what is happening is we've got 2 benzene rings over there. In terms of the osmolar particles, we've still got the anions and cations, and then the iodine, because there are 2 benzene rings, doubles up. So there are 6 iodine molecules. So the ratio we get of the osmolar particles to iodine is 2:6, which is equivalent to 1:3. Now moving on to the non-ionic ones. Non-ionic ones again can be monomers or dimers. When we're talking about non-ionic monomers, there is only one osmolar because there is no anion or cation, and a monomer will give us 3 iodine molecules. So what the ratio we've got of osmolar particles to iodine is 1:3. When we move on to dimers, this changes because dimer would have 2 benzene rings, and hence we'll have 6 iodine molecules, but there's only one osmolar particle because there are no anions and cations, so the ratio is 1:6. So when you're selecting your contrast, the non-ionic dimers are the ones which are delivering most ionic molecules with the least amount of osmolality. Why? Because they're dimers, so each benzene ring is contributing to 3 iodine molecules. So total iodine molecules are 3 into 2, which is equal to 6. And because they're non-ionic, so there is only one osmolar particles. There are no anions and cations. So you get a ratio of 1:6. So theoretically, this should be the most effective contrast we are using with least amount of complications. But the common ones we use in our clinical practice happen to be non-ionic monomers such as Omnipec. So this slide shows you an example of different types of contrast agents. If you look at the second column, you see whether they're monomers or dimers. And then the ionic ones have been separated from the non-ionic ones. So Omnipec is actually a monomer and it's non-ionic. And the 350, which we don't use for spinal procedures, had an osmolality of about 800 plus. And it is still, because it's less than 3 times, so it's still classified as low osmolality. Whereas the high osmolality one would be more than 3 times. So you can see the examples over there. There are mostly, you can see the ionic ones. So moving on to the next section, the adverse reactions. I think this is a very important section. The adverse reactions can be either general or they can be organ specific. Organ specific generally tends to involve the renal or the nervous system or the cardiac system. Now the general reactions, if you get, they can happen immediately or they can be delayed. The delayed ones are classified as the ones which are occurring after 1 hour to 1 week of the procedure. These are delayed because these are T-cell mediated, and they are generally not so severe. Whereas the acute one, which occurs within 20 minutes, are often the most severe ones, and it can even be fatal reactions. So you can also classify these adverse reactions based on the mechanism involved or the underlying mechanism responsible for these. So one such classification is dividing them into anaphylactic and anaphylactoid reactions. Now both of these can be equally severe and life-threatening. However, the mechanism which is involved is different. So in anaphylactic reactions, you'll have IgE antibodies which will cause liberation of chemical mediators from basophils and mast cells. Whereas in anaphylactoid reactions, the mechanism involved may be activation of certain enzymes or coagulation cascade, but the eventual final step is the same, where you have chemical mediators being released from basophils and mast cells. Now, it's important to understand that the contrast molecules are not so big in size, so the chances of antibody generation with these are a little less, and hence you see more of anaphylactoid reactions rather than anaphylactic reactions. These anaphylactoid reactions, they generally occur in first 20 minutes and are often related to the dose which has been given. It's important not to take these lightly because they can be as life-threatening as the anaphylactic reactions. Another type of reactions which we see are non-anaphylactoid reactions, which are based on the physiochemical properties of the contrast agent. Now, when we talk about physiochemical properties, we talk about whether they are ionic or non-ionic, what is the iodine content they have got, what is the osmolality, what dose we have used, and how this dose has been given, I mean by what route. All these factors would kind of influence the generation of symptoms such as vasovagal episodes or a warm sensation or a metallic taste. So these are all types of non-anaphylactoid reactions. Now, on the whole, the incidence of allergic reactions with these contrast agents are quoted differently in different studies, and that's understandably so. But what comes out as a consensus in all of these studies is that the low osmolar contrast media, which includes the iso and isoosmolar, and the ones which have their osmolality less than 2 to 3 times of the plasma osmolality, they are generally safer and associated with less reactions. Another point I like to make out over here, kind of highlight over here, is that we're often taught that shellfish allergy in a way correlates with contrast allergy. So if you've got shellfish allergy, you're more likely to have contrast allergy. Now this has been proved wrong in the subsequent analysis which has been done, and most people believe this is not the case, because the allergy to shellfish is not because of the iodine, but because of a protein by the name of tropomyosin. So the iodine content of the contrast is not the same. The iodine allergy from the contrast is not the same as that from the shellfish. Now, but there are other factors which you can screen for in a patient when you're giving them a contrast, which can help you pick up the high risk ones separately. These are patients who've got history of asthma, who've got prior contrast allergies, or young, anxious, who may have renal disease or cardiac disease. All these things make people more likely to have contrast allergies, and these are the people where you've got to be extra careful. But fortunately, most of the reactions we get are kind of mild and normally settle down within, say, the first 24 hours. So as we've discussed this point before, that adverse reactions are related to the osmolality and whether the contrast agent being used is ionic or not. So when it comes down to picking up these cases who are more likely to get an allergy, you might also want to do something about it, so that if you are using a contrast agent, then the chances of that happening are reduced, or the symptoms are milder. And there are pre-treatment protocols in place for this, and most of these protocols would use either steroids or a combination of steroid and an antihistaminic. One such protocol is the Greenberger protocol, which uses prednisolone given at specific time periods prior to giving the contrast, and then an antihistaminic given about an hour before the contrast is given. Pre-testing, pre-testing as such is not something which is recommended, because it does not help us to kind of predict whether a person is going to be getting a contrast reaction or not. If somebody's had a contrast reaction and it's quite severe and you really want to avoid contrast, but the procedure is such that you cannot afford to do that, then you have another option which you may want to consider, and these are gadolinium based contrasts which are used in MRI. Fortunately, I've never had to use these, but this is something you should be aware of, and probably worth discussing it with one of your radiology colleagues if you're planning to use this. So there are differences between the normal omnipaque-like contrast and a gadolinium-based contrast, which you should be aware of if you're trying to use it. One such point is that these are less radiodense, so you might have to rely on digital subtraction to get a better image. Also, the volumes you want to use should be limited to less than 1 ml. That's what's used if a myelography is being performed, as higher doses may lead to complications. So if you're using such a small volume, then you might want to give smaller aliquots and then use digital subtraction to get the best imaging. Now, there are no reported complications following fluoroscopy guided injections, such as transforaminal nerve root blocks or SIJ injections or medial branch blocks. But then there is a reported complication after an interlaminar epidural, where a patient was discharged home and subsequently had seizures, and on repeat MRI scans they found contrast in the higher areas in the brain and the spinal region. So just at the end, I like to highlight some key points from the whole presentation. Number one, if you are doing a procedure where you're going to use the contrast, always warn your patient and consent them for the allergy risk. As the allergic reaction is most likely to occur in the first 30 minutes, it's probably worth monitoring them at least for the first 30 minutes after the procedure. Now, if you are using the contrast agent, it's best to use a non-ionic one with low osmolality. And then even in these, like if you're using Omnipeg, you should be aware that Omnipeg 140 and 350 are not licensed for intrathecal use, so please use alternative ones. And then if you have no other choice in terms of the contrast, and somebody's got a severe allergy and you already have to use a contrast, then probably worth considering gadolinium-based contrast agent. Now, that brings us to the end of the presentation. The faculty for this presentation was me, Dr. Amod, and the other people who were involved in this program include Dr. Shetty and Dr. Puneet. And this presentation was brought to you by Education Without Barriers. I hope that you found it useful. Thank you for listening. Bye-bye.